Let's talk about Chapter 15, the Pregnancy and Childbirth section. I like to think of this section as O for obstetrics, so the codes start with O, and I can easily remember that this is the pregnancy section. General rules for obstetric cases. 1. Codes from this chapter and have sequencing priority. So O for obstetrics, their priority. If there's other codes with other letters before them, the O code should go first. 2. Chapter 15 codes used only on the maternal record. These are only used on the maternal record, not on the newborn baby's record. Please remember that because that could be a trick question. Codes for the newborn baby are coded from a different section. The final character for trimester. The majority of codes in Chapter 15 have a final character indicating the trimester of pregnancy. This could be a quick tip if you're on a test and you see that it has the wrong trimester on there. The time frames for the trimesters are indicated at the beginning of the chapter. If the trimester is not a component of a code, it is because the condition always occurs in a specific trimester, or the concept of trimester of pregnancy is not applicable. Certain codes have characters for only certain trimesters, because the condition does not occur in all trimesters, but it may occur in more than just one. Assignment of the final character for trimester should be based on the provider's documentation of the trimester by the number of weeks for the current admission encounter. This applies to the assignment of trimester for pre-existing conditions, as well as those that develop during or are due to pregnancy. 7th character for fetus identification. Where applicable, a 7th character is to be assigned for certain categories, and the categories are listed in parentheses to identify the fetus for which the complication code applies. Assign 7th character 0 for a single gestation, or when the documentation is in the record is sufficient to determine the fetus affected and is not possible to obtain clarification, when it is not possible to clinically determine which fetus is affected. Now let's talk about the selection of the OB principal or first listed diagnosis. When a patient comes in for a routine outpatient prenatal visit. When a patient comes in for these visits and there's no complications are present, a code from Z34, Encounter for Supervision of Normal Pregnancy, should be used as the first listed diagnosis. Supervision of high-risk pregnancy. Codes from categories 009, Supervision of high-risk pregnancy, are intended for use only during a prenatal period. For complications during a labor or delivery episode as a result of a high-risk pregnancy, assign the applicable complication codes from Chapter 15. If there are no complication codes during labor or delivery episode, assign 080. That's important. So that would be on any encounter with a normal pregnancy during labor. For routine prenatal outpatient visits for patients with high-risk pregnancies, a code from category 009, Supervision of high-risk pregnancy, should be used as the first listed diagnosis. Episodes when no delivery occurs. In episodes when no delivery occurs, the principal diagnosis should correspond with the principal complication of the pregnancy, which necessitated the encounter. Should more than one complication exist, all of which are treated or monitored, any of the complication codes may be sequenced first. Now, this next guideline is important. When a delivery does occur, when an obstetric patient is admitted and delivers during that admission, the condition that prompted the admission should be sequenced as the principal diagnosis. If multiple conditions prompted the admission, sequence the one most related to the delivery as the principal diagnosis. A code for any complication of the delivery should be assigned as an additional diagnosis. In cases of cesarean delivery, if the patient was admitted with a condition that resulted in the performance of a C-section, that condition should be selected as the first diagnosis. Outcome of delivery. Anytime a baby is born, the outcome of the delivery should be on the claim. A code from category Z37, outcome of delivery, should be included on every maternal record when a delivery has occurred. These codes are not to be used on subsequent records or on the newborn record. Fetal conditions affecting management of the mother. Codes from categories 035 and 036 should be used. Codes from 035, maternal care for known or suspected fetal abnormality or damage, and 036, maternal care for other fetal problems, are assigned only when the fetal condition is actually responsible for modifying the management of the mother. Gestational diabetes. Gestational pregnancy-induced diabetes can occur during the second or third trimester of pregnancy in women who were not diabetic prior to pregnancy. That's important. They were not diabetic prior to pregnancy. Gestational diabetes can cause complications in the pregnancy similar to those of pre-existing diabetes. It also puts the women at greater risk for developing diabetes after pregnancy. Codes for gestational diabetes are in category 024.4. No other code from category 024 diabetes in pregnancy, childbirth, or peripartum should be used with code 024.4. The codes under subcategory 024.4 include diet-controlled, insulin-controlled, and controlled by drugs. If a patient with gestational diabetes is treated with both diet and insulin, only the code for insulin-controlled is required. If a patient with gestational diabetes is treated with both diet and oral medications, only the code for controlled by oral drugs is required. Code Z79.4 for long-term use of insulin, or code Z79.84 for long-term current use of oral drugs should be assigned with the code 024.4. Like I mentioned before, in Guideline N1, encounter for full-term uncomplicated injury. Code 080 should be assigned when a woman is admitted for a full-term normal delivery and delivers a single healthy infant without any complications. Code 080 is always a principal diagnosis. It's always first. It is not to be used if any other code from Chapter 15 is needed to describe a current complication of the delivery. Additional codes from other chapters may be used with code 080 if they are not related to or are in any way complicating the pregnancy. Uncomplicated delivery with resolved antepartum complication. Code 080 may be used if the patient had a complication at some point during pregnancy, but the complication is not present at the time of the admission for delivery. As I said before, along with 080, a outcome of delivery code must be on the claim. It's usually the last listed code. Z37.0 for single live birth is the only outcome of delivery code appropriate to use with 080. You could even write that next to 080 in your book, because basically if you use 080, you must use Z37.0. The peripartum and postpartum periods. Peripartum and postpartum periods begin immediately after delivery and continues for 6 weeks following delivery. The peripartum period is defined as the last month of pregnancy to 5 months postpartum. Peripartum and postpartum complication. A postpartum complication is any complication occurring within that 6-week period. Let's talk about termination of pregnancy and spontaneous abortions. Abortion with live-born fetus. When an attempted termination of pregnancy resulted in a live-born fetus, assign code Z33.2 encounter for elective termination of pregnancy and code from category Z37 outcome of delivery. Retained products. Subsequent encounters for retained products of conception following a spontaneous abortion or elective termination of pregnancy without complications are assigned 003.4. Incomplete spontaneous abortion without complication or codes 007.4 failed attempted termination of pregnancy without complication. This advice is appropriate even when the patient was discharged previously with a discharge diagnosis of complete abortion. If the patient has a specific complication associated with a spontaneous abortion or elective termination of pregnancy, in addition to retained products of conception, assign the appropriate complication in category O03 or O07 instead of code O034 or O074. Complications leading to abortion. Codes from Chapter 15 may be used as an additional code to identify the documented complication of the pregnancy in conjunction with the codes in category O04, O07, and O08. Chapter 18 are R codes. And like I said before, R codes are symptom codes. This is something to remember because remember, a symptom is never coded if a diagnosis related from that symptom is in the documentation. For example, if you come in with abdominal pain and you get diagnosed with the stomach flu, or you get diagnosed with colitis, then the abdominal pain is irrelevant because we have a definitive diagnosis. Use of symptom codes. Codes that describe symptoms and signs are acceptable for reporting purposes when a related definitive diagnosis has not been established, like I said. Use of a symptom code with a definitive diagnosis. Codes for signs and symptoms may be reported in addition to a related definitive diagnosis when the sign or symptom is not routinely or commonly related to the diagnosis. Obviously, it is commonly related that abdominal pain comes along with colitis or the stomach flu. But if something else that's usually not related to that condition occurs, then you can report it. Signs or symptoms that are associated routinely with a disease process should not be assigned as additional codes. Repeated falls. Code R29.6 is a code for repeated falls. It's for use for encounters when a patient has recently fallen and the reason for the fall is being investigated. Code Z91.8, history of falling, is for use when a patient has fallen in the past and is at risk of future falls. When appropriate, both codes can be reported. Let's talk about Chapter 19, injury, poisoning, and certain other consequences of external causes. These are S codes to T codes. Now remember, S codes are injury codes. This will help you. In this chapter specifically, there are a lot of seventh characters. Remember, those are the alpha characters at the beginning of the section that go in the seventh spot. This is also where the placeholder X comes into play a lot. Most categories in Chapter 19 have a seventh character requirement for each applicable code. Most categories in this chapter have 3 seventh character values. A for the initial encounter, D for the subsequent encounter, and S for sequela. Categories for traumatic fractures have additional seventh character values. Let's talk about seventh character A. Seventh character A, initial encounter, is used for each encounter where the patient is receiving active treatment. So, for instance, if the patient has a traumatic fracture of their ankle and they're seen in the office, they get an x-ray, the A will go at the end of that visit code. Then the patient's going to go to surgery. They're going to get surgery, and on that visit on a separate day, the A will still be used because they are still being actively treated. The D starts to be used when the patient is not receiving active treatment and is just coming for follow-up care. Seventh character S stands for sequela. It is used for complications or conditions that arise as a direct result of a condition, such as a scar formation after a burn. The scars are sequela of the burn. When using seventh character S, it is necessary to use both the injury code that caused the sequela and the code for the sequela itself. The S is added only to the injury code, not the sequela code. That's important. So basically, if a patient had a fracture of their ankle and a scar formation was caused by that, you would code the fracture code with the S behind it and the scar formation. Now let's talk about coding burns and corrosions. ICD10 makes a distinction between a burn and a corrosion. The burn codes are for thermal burns, so heat, except sunburns, and come from a heat source such as a fire or a hot appliance. The burn codes are also for burns resulting from electricity or radiation. Corrosions are burns due to chemicals. So think corrosion of a battery, think of corrosion chemicals. Current burns, T20 through T25, are classified by depths. So how far did the burn go down in the skin? And by agent. Burns are classified by depth as first degree, second degree, and third degree. First degree is just the first layer of your skin. Second degree goes down into the dermal layer, which is the second layer of your skin. And full thickness goes all the way through your skin. Sequencing burn and related condition codes. Sequence first the code that reflects the highest degree burn when more than one burn is present. So make note of that. The highest degree goes first. When the reason for the admission or encounter is for treatment of external multiple burns, sequence first the code that reflects the burn of the highest degree. When the patient has both internal and external burns, the circumstances of admission govern the selection of the principal or first listed diagnosis. When a patient is admitted for burn injuries and other related conditions such as smoke inhalation or respiratory failure, the circumstances again designate which code goes first. Which one are they being treated for, basically? Burns of the same site. Classify burns of the same site, 3-character category, but of different degrees to the subcategory identifying the highest degree. So if you have 2 burns, same site, 2 different degrees, code the highest degree. Assign codes from T31, burns classified according to extent of body surface area involved, or T32, corrosions classified according to extent of body surface involved when the site of the burn is not specified or when there is a need for additional data. It is advisable to use category T31 as additional coding when needed to provide data for evaluating burn mortality, such as that needed by burn units. It is also advisable to use category T31 as an additional code for reporting purposes when there is mention of a third-degree burn involving 20% or more of the body surface area. Category T31 and T32 are based on the basic rule of nines. In estimating body surface area, head and neck are assigned with 9%, each arm 9%, each leg 18%, the anterior trunk 18%, posterior trunk 18%, and genitalia 1%. Providers may change these percentage assignments where necessary to accommodate infants and children who have proportionately larger heads. The last chapter, chapter 21, refers to influencing health status and contact with health services. Use of Z-codes in any healthcare setting. Z-codes are for the use in any healthcare setting. Z-codes may be used as either the first listed diagnosis or secondary code depending on the circumstances of the encounter. Certain Z-codes may only be used as the first listed or principal diagnosis. If you look at these codes, there should be a symbol and a symbol guide at the bottom of your page when you see them. We'll look at that a little bit further later. Z-codes are not procedure codes or a diagnosis. A corresponding procedure code must accompany a Z-code. Here are the different types of categories for Z-codes, and this will help you know how to look them up. Contact and exposure, inoculations and vaccinations. So if you're just going in for a vaccination and you don't really have a diagnosis of anything, the Z-code would be used for the vaccination procedure. Status codes. These are a major part of the Z-codes. Status codes indicate that a patient is either a carrier of a disease or has a sequela or residual of the past disease or condition. This includes such things as presence of a prosthetic mechanical device. A status code is informative because the status may affect the course of treatment and its outcome. A status code is distinct from a history code. The history code indicates that the patient no longer has the condition. A status code should not be used with a diagnosis code from one of the body system chapters. If the diagnosis code includes the information provided by the status code, For example, code Z94.1, heart transplant status, should not be used with code T86.2, complications of heart transplant. Number 4, you have history of. These are the common Z codes that you will see. You have two types of histories, personal history and a family history. Personal history codes explain the patient's past medical conditions that no longer exist and is not receiving treatment for. Family history codes are for the use of a patient's family who has had a particular disease that causes the patient to be at a higher risk. Personal history codes may be used in conjunction with follow-up codes, and family history codes may be used in conjunction with screening codes to explain the need for the test or procedure. History codes are also acceptable on any medical record regardless of the reason for visit. It should probably go last in that case, though. A history of an illness, even if no longer present, is important information that may alter the type of treatment ordered. Screenings. Number 5. Screening. Screening is testing for disease in seemingly well individuals so that early detection and treatment can be provided for those who test positive for the disease. The testing of a person to rule out or confirm a suspected diagnosis because the patient has some sign or symptom is a diagnostic examination, not a screening. In these cases, the sign or symptom is used to explain the reason for the visit. An example of this would be a patient going in for their colonoscopy, and they're going in for a screening colonoscopy. They don't have any signs or symptoms. But however, if they have abdominal pain or any other sign or symptom, that would be coded instead of the screening diagnosis code. Observation is number 6. There are 3 observation Z code categories. They are for use in very limited circumstances when a person is being observed for a suspected condition that is ruled out. The observation codes are not for use if an injury or illness or any signs or symptoms related to the suspected condition are present. So these are rarely used. In such cases, the diagnosis and symptom code is used with the corresponding external cause code. Aftercare is number 7. Aftercare visit codes cover situations when the initial treatment of a disease has been performed and the patient requires continued care during healing or recovery phase. For example, the aftercare Z code long-term consequences of disease should be used for patients who are in their postoperative period for a certain surgery. Finally, number 16 is important that I wanted to mention. This is a place where it's a list of Z codes that can only be the first listed diagnosis. This is helpful because I have seen on certain tests where they'll ask, what Z code can be listed as primary. Pick the correct answer. So you could just easily come to this list and see if it's on this list.